a combined Harvard program. Her clinical practice focuses on the surgical treatment of urologic cancers. The lecture will be around 45 minutes, and then we'll reserve the last 15 minutes for questions and case presentations. I'll hand it off to you, Dr. Dio.
Oh, great, thanks for the introduction. I can't, oh, actually, hold on, I'm trying to figure out how to share my slides. Okay.
Oh, I can see him now.
Does that work? Okay, great. And is the slide sort of the whole page?
Yeah, it is.
Okay. And if I do that,
then I can see the upcoming slides too.
Okay, so let's leave it like that then. Okay, great. So, well, thank you so much to IVUmed for setting up this great education initiative, and thank you so much for allowing me to spend the next hour to talk about prostate cancer with everyone here. And I'm really excited to give this presentation and also to talk about the case that you prepared a little bit later. So without further ado, let's get started. And I've been asked to talk about prostate cancer prevention and early detection. So I'll split this presentation sort of in two, and we'll start talking about prevention and follow with early detection. I have no disclosures. So as we all know, prostate cancer is very common among men. And on a worldwide scale, it's actually the most prevalent cancer worldwide in men. It's also the 5th leading cause of cancer mortality, according to WHO data from 2018. And the WHO projects that by 2040, the incidence of prostate cancer, so newly diagnosed cases, will almost double. So what causes prostate cancer, and what are some risk factors, and how can we prevent this from happening? These are some of the risk factors that we're going to explore in the next few slides. So first off, we know that there is a familial aspect of prostate cancer. We know that men who have a family history of prostate cancer are at increased risk of developing prostate cancer themselves. And this is really specific to first-degree family relatives. Now, what does first degree mean? It means a parent, a sibling, or an offspring. So therefore, uncles and cousins and nephew don't really count. So men who have a first-degree relative with prostate cancer are about twice as more likely to develop prostate cancer themselves. And we know that this risk increases with the increased number of first-degree relatives. So for example, men who have a father and a brother diagnosed with prostate cancer, or 2 brothers diagnosed with cancer, their own risks can actually increase and be 5 or even 7 times higher than the general population. While there is an increased risk of developing cancer, we know that also sometimes these cancers will develop a little bit earlier, so they have earlier disease onset. However, the good news is that these cancers tend to have similar aggressiveness and clinical outcomes compared to the non-hereditary types. We also know that there are certain germline mutations associated with prostate cancer, and I've listed most of them there on the slide. I do want to highlight the BRCA2 gene, and that's because this is the only one that's associated with not only an earlier onset, but more aggressive types of prostate cancer, and they tend to have slightly worse clinical outcomes. We know that there is there's a racial link with prostate cancer. So compared to Caucasian men, men of African descent actually have a 63% higher incidence of prostate cancer and have almost a 2 times increased risk of dying from prostate cancer. We also know that African American men tend to have earlier onset of their disease. The disease can be more aggressive, and there's a higher risk of progression to metastases. Now, some of that aggressivity of the disease may be biological, but some of it may also be related to socioeconomic status and access to health care. So a lot of these studies were done in North America, and they've also found that there was actually a difference in the treatment patterns of prostate cancer by race, in that African American men tend to receive less aggressive therapy at every stage of disease. So this increased risk of prostate cancer in African American men may in part be due to genetic predisposition, but some of the worst outcomes may actually be also have some environmental and access to healthcare factors. So metabolic syndrome and diet. We think there may be some dietary and metabolic where prostate cancer may have some socio-metabolic syndrome, and this is largely due to the observation that Japanese men or Asian men tend to have a lower risk of prostate cancer. But more interestingly, when Japanese men move from Japan to North America, their risk of prostate cancer actually increases to nearly the same risk as their Caucasian peers. So this led to the belief that maybe some of this risk was due to environmental and dietary factors. So the research in this area is a little bit controversial. When we look at metabolic syndrome and its association with prostate cancer, we see that men with high blood pressure or increased waist circumference have been associated with an increased risk of cancer. However, having multiple components of metabolic syndrome is somehow protective. So that's sort of conflicting data. It's also been shown that metformin may be associated with the decreased risk of prostate cancer in some observational studies. However, none of the other oral anti-glycemic medications have shown this risk. And this effect was not consistently seen throughout some other studies. It's also been observed that there may be a link between obesity and prostate cancer, and that obese men may have a lower risk of low-grade cancer, but a higher risk of high-grade cancer. And then lastly, there's a number of dietary factors that have been studied, and the results have not entirely been consistent. And then lastly, androgens. So we know that there is a link between testosterone and prostate cancer. So people have looked at ways to use medication to prevent prostate cancer, specifically with the use of 5-alpha reductase inhibitors. So there are two very large, well-known studies that looked at the use of finasteride and dutasteride for prevention of prostate cancer. So essentially what these studies have shown is that by randomizing patients to either finasteride or placebo, or in the other study, dutasteride or placebo, they found that men on these medications may have a slightly decreased risk of developing prostate cancer. However, it really reduces only low-grade prostate cancer. And in fact, men who were on these medications had an increased risk of more aggressive tumors. Now, there's no clear causal link, and we don't actually think that these medications cause the cancers themselves. The more likely case is that the medications will shrink the size of the prostate, which increases the detection of these aggressive tumors. But more importantly, these medications have not led to any difference in survival. And that's why they are not really recommended for prostate cancer prevention. So just to sort of summarize, if we look at some of these risk factors we talked about, there really is no effective preventative strategy to reduce the risk of developing prostate cancer. And that's because a lot of these risk factors, first of all, are not modifiable. Things like family history, genetics, race, these are not things that we can change. The link with metabolic syndrome is not super clear. And lastly, we've seen studies looking at chemo prevention, and that has not really been effective. So that's why when we talk about prevention of death from prostate cancer, we're really looking at early diagnosis and therefore early treatment. So prostate cancer screening, does it work? So if we look at some observational studies back in the 80s and 90s, where PSA was first discovered, there was a sharp increase in the incidence of prostate cancer, which is as expected when PSA was first discovered, and then the prostate cancer rate sort of leveled off. But more importantly, we see that death from prostate cancer actually decreased with the introduction of PSA. So several large studies have looked at the use of PSA screening in preventing death from prostate cancer. And there's 3 large studies that we'll talk about. We'll look at their screening protocols and their results. So the first one is the PLCO study. This is one that was conducted in North America. There was also another study that was conducted in Europe, and the third one conducted in Sweden. And as you can see, the number of men enrolled in all these studies is a lot. There's tens and thousands or even hundreds of thousands of men involved in these studies. And basically what they did was that they randomized the men to either screening or no screening. Most of these studies enrolled men starting in around the 50s, and they would screen up until the late 60s or mid 70s. The screening protocols that they used in these studies are a little bit different. In the PLCO study, PSA and rectal exam were tested annually. In the European study, they were tested every 4 years, and in the Swedish study, every 2 years. The PSA cutoff for recommendation of biopsy is also a bit different between the studies. In the PLCU, they used a cutoff of 4. In the European study, they used a cutoff of 3, and the Swedish study cutoff of 2.5. So you could see across the board with all 3 studies, there was a pretty long follow-up. And what's kind of interesting with the results is that they show different things. So in the American study, they found there was no benefit with screening when we look at prostate cancer mortality, whereas in the European studies, they found a significant reduction. So in the European trial, they found that the number of patients who needed to be screened or invited to screen to save one person from dying from prostate cancer was about 1,000. And the number of cases that need to detect, the number of prostate cancers that we need to diagnose is around 37. Similarly, in the Swedish study, which was probably a little bit more homogeneous and they screened a little bit more frequently, the number of patients that needed to be screened was only about 130, and the number of cases that need to be diagnosed was 13 to save one person from dying from prostate cancer. So why did this study give us sort of a conflicting result? Well, like any study, there are some limitations. In the PLCO study, there was a high contamination rate in that the patients who were not supposed to be, were not randomized to screening, so who were not supposed to get any PSA testing, out of that group, 80% of the patients actually were screened at least once. So they've had at least one PSA done at some point. So essentially, because of that high contamination rate, we're not really comparing screening versus no screening. It's rather just screening versus sporadic screening. And that may explain why we did not find a difference between those 2 groups. And also, out of the patients with the elevated PSA, not everyone was biopsied. In the European trial, as you noticed before, there was a low intensity of screening. So PSA was tested every 4 years, and some people think that that may be not frequent enough. And then one of the limitations of the Swedish study is that this was a very homogeneous population, mainly Caucasian from Sweden. So the data may not be generalizable to people from other parts of the world, for example. Some other limitations that apply to all 3 studies is that in the men in the screening arm who end up undergoing a biopsy, many underwent a 6-core prostate biopsy rather than the standard 12-core. So that would decrease your cancer detection rate. They also did include men with high risk factors, such as people with positive family history or African descent. And lastly, they did not include younger men. And now, why is that important? Well, there's some more data that came out later that show that a baseline PSA testing might actually be more useful and a better predictor for dying of prostate cancer later in life. So what some of these studies showed is that your baseline PSA, when we test it in your mid-40s or mid-50s, if your PSA is in the highest 10th percentile at that time, your chance of dying from prostate cancer later on is higher. So when we put all this information together, this is the NCCN guidelines for PSA screening, and this is what we use a lot in North America. So what we recommend is that first you start off by taking a history and a physical exam, and that's how you identify some of the risk factors for prostate cancer, such as a family history of prostate cancer, a race, any family history of germline mutations, for example. And then you start with a baseline PSA and a rectal exam. What the NCCN recommends is that we start screening at around age 45 and at age 40 for those with risk factors, such as African Americans and those with germline mutations. Based on the first PSA, that dictates how often you need to repeat your PSA in the future. So for example, if your first PSA at age 45 was less than 1 and the rectal exam is normal, you can repeat testing at a wider interval every 2 to 4 years. If your baseline PSA is between 1 to 3, then recommend repeat testing every 1 to 2 years. And if the PSA is higher than 3, or there's a suspicious rectal exam, then we talk about possibly doing a prostate biopsy, but again, if there are indications. And then generally, we recommend against screening in men who are older than 75 years or who have a shorter life expectancy. And as you can see here, the cutoff of what we consider abnormal in this age group is also a little bit higher. So what's the threshold for biopsy? As I mentioned before, using a PSA alone is likely not sufficient. So men who have an elevated PSA and a suspicious rectal exam, I would say definitely needs biopsy. There are risk calculators out there that you can find on the internet. And basically these risk calculators use these big studies have been conducted, and you basically plug in all your clinical factors like your patient's age and prostate size and PSA and rectal exam findings. And based on those factors, it gives you sort of that risk of what is the likelihood you'll find cancer, and you can use that to guide whether or not you should do a biopsy. In addition to PSA, there are also PSA derivatives and biomarkers that we can use. I put in age-related PSA and PSA velocity and cross it off because these are things that we've talked about historically, but we know now that they're actually not great predictors for likelihood of detecting cancer. PSA density can be a little bit more useful, the percent free to total PSA, and some of these other biomarkers can be useful when available to help guide you whether or not the patient needs a biopsy. And then lastly, multiparametric MRI, which has become more and more popular even in the pre-biopsy setting to help guide us whether or not a biopsy is indicated. So sort of take-home message from that second section, men under the age of 40 do not need screening. Men with risk factors such as family history, germline mutations, or of African descent, you can start screening a little bit earlier at age 40. For everyone else, consider screening at age 45. If you want to start screening, start early, get a baseline PSA, and that determines the frequency of the PSA testing. The indication of biopsy should depend on clinical factors and not just the PSA itself. And consider stop screening once the patient reaches age 75 or if the life expectancy is less than 10, 15 years. So that's it. Thank you for your attention, and just let me know if you have any questions.
Oh, Dr. Chitramo, you're on mute.
Oh, sorry.
Oh, you're
I
fine.
was saying thank you for the lecture, and again, thank you for give time to us. I will invite our colleagues, those can have any question. We can start now. Anyone with questions?
Dr. Yu, can you hear me?
Yep, I can hear you.
Yeah. Do you have any experience with urinary spermine? I think it's now on the move, I say. Instead of PSA, urinary spermine, do you have already any news about it?
Sorry, I didn't quite catch that. Can you just repeat the question?
I'm asking you if you are using already urinary spermine.
If we're using
Urinary spermine.
urinary,
I read a lot about last 2 years about spermine. That's a new laboratory that a new test that is going to, they say, that is going to substitute PSA determination. You don't know nothing about it.
no, I don't know if it's because I'm hearing it. I'm not hearing it quite clearly, but not that I'm aware of.
Okay, PSA is always and now and for the future the main test we have to screen prostate cancer. Is that okay?
Yeah,
Is that
yeah.
your opinion?
Yeah, so when it comes to screening, you know, obviously it's a shared decision making, but once if you decide and when the patient wants to go down that screening route, the PSA is sort of the first marker that I would use. When the PSA, if it's a little bit higher and when, you know, and you're considering biopsy, I think there's a lot of adjunct and biomarkers and derivatives that I talked about that can be considered to help guide your decision to whether or not biopsy. But when it comes to screening, I think PSA is still sort of the standard marker that we would use and recommend.
Okay, thank you.
Hello, may I? This is Enrique Banze. May I ask a question to Dr. Lalis?
Absolutely.
Dr. Lalis, congratulations for your presentation first. And secondly, I lost a bit your presentation for some reasons of connections, but I could follow it a bit. And one of the things witnesses in your presentation you were mentioning, perhaps that was my understanding, that the African American in this case, or the African in general, are much more prone to have a cancer, prostate cancer. Is there any special reason, if we compare it with the European, for instance, is there a specific or special reason for the Africans to be more subject to such concern? Is that has to do with the climate and specific conditions? Is that a specific food? Why is that? Thank you.
Yeah, you bring up a great point. So, you know, a lot of the studies that I presented were done in North America, so they're African Americans, but, you know, people of African descent. There's also some studies showing that men in the Caribbeans of African descent are also at higher risk. And, you know, most likely there is a genetic component that is sort of the cause. In North America, there might be also some access to healthcare issues that I was saying that may sort of exaggerate a little bit some of the worst outcomes and risk of metastases that we notice. But largely, it seems like there is likely some sort of genetic component that led to the increased risk. Do you want to, should we move on to the case if there's no other questions? Maybe that can sort of stimulate some discussion also.
I guess we have more questions. Yeah, I have one question.
Yeah.
Is about the screening of patients with the prostate cancer. In your presentation, you said that a person above 75 years old, you advise to not screen. What I am wondering is about if these patients got symptoms, they got obstructive symptoms, we screen this patient or not?
That's a great question. And that's the important point to note here is when you do a PSA testing and someone who is symptomatic, it's technically not screening. Screening by definition is testing somebody who has no symptoms, and you want to detect their cancer early so that it's at a point where it's still treatable and curable. And somebody who already has symptoms, you're doing your PSA not for screening purpose, but to diagnose a condition. So if somebody is, you know, symptomatic, in retention, has a very, you know, suspicious rectal exam, for example, then I would definitely consider doing a PSA, and it wouldn't be considered a screening PSA, it's a diagnostic PSA.
And I have another question. Thank you for your answer first. And I have another question. Seems that most of your recommendation for screening and the treatment is linked with the, let's say, a race pattern from USA. And how we realize that the prostate cancer is more aggressive in African American, in Africans itself. Start screening before 40 years old?
You know, I think that's a really interesting question, and you know, I wish there were more studies done in Africa, and maybe that's something that I would encourage, you know, people to sort of, you know, consider that. And the reality is, most of our data we have is from North America, so we would use that to guide our recommendations. And the reality is we don't have, you know, that much data coming from Africa. So I'm definitely sort of extrapolating based on some of the data that we do know. So you raise a great question, and the reality is I don't know the answer to that. I do wonder, you know, if there is a even higher risk in men in Africa. Should screening be considered even earlier than 40? And if that's the case, what would be considered also a normal PSA, and how do you continue screening afterwards? So I think you raised some really, really interesting questions, and there's definitely room for more research in that space.
Thank you. In fact, the reason why I am asking that is because we had a patient that have been diagnosed with the prostate cancer with the age of 35, and he have been submitted to radical prostatectomy. And when you are reading in book or an article, you will not find that a person that have been submitted to radical prostatectomy with the 35.
Yeah.
And it seems to me that the pattern can be changed when we are talking about Africans.
I'm very curious about this case that you talk about. What was the Gleason score in this young patient with prostate cancer, and how was it diagnosed? Was he symptomatic? How was the prostate cancer discovered?
Yes. In fact, this patient was, I was seeing this patient this year, and he was 40. So, but he told me, and I was seeing his record from 5 years ago, that he have been diagnosed prostate cancer. The first urologist that was assisting him was thinking that it was prostatitis or some another neurological obstruction. But when decided to screen with PSA, and he was above 10. I don't remember exactly the number now, but it was above 10. And when he decided to go to the biopsy, was a Gleason 7. So they decided to do radical prostatectomy, and in fact, he's doing fine. He's doing very fine. I just met him because he came with the erectile dysfunction. So, but he's 5 years later after the surgery. So, he's a really interesting patient that I have met.
Yeah, absolutely. That's really interesting. The reason I was curious about the Gleason score is that you know, there are some old studies, autopsy studies that show that men as young as they're in their 20s can actually have prostate cancer, and these were autopsies conducted during the war, when some of these young men died of other causes during the war, and they performed autopsies and found that as high as, I think, 20% of men in their 20s and 30s can actually have prostate cancer. The reality is a lot of these are low-grade Gleason 6 cancers that, you know, have very low risk of growing and metastasizing, that one of those low-grade cancers that we kind of almost don't want to detect. So and the case that you mentioned, it's certainly very unusual to see that type of clinically significant cancer in a young man in his 30s. So yeah, thank you for sharing that case. It's very interesting.
You're welcome. In case that we don't have any more questions for a while, maybe I will suggest that our colleague make the presentation of the clinical case. Of course, if you agree with that.
Sure, that sounds great.
So I would like to invite Dr. Leland, Beatrice Leland, to make a presentation of the case.
Hello, good evening, everyone. Am I supposed to put the slides on? Because I really don't know how to do that.
At the bottom of your screen, there should be a green button that says share screen.
Oh yeah, right, great. Let me just open it. So, good evening, everyone. I will just present now a clinical case of a patient that we have here in the Hospital Central of Maputo. So, case summary. It's a male, 68 years old. He was referred to urology. To urology with a history of a dysuria and pain in the hypogastrum 7 months ago, which progressed to urinary incontinence. Also reports nectaria 3 to 4 times, and also he was referring urinary urgency. Currently, he has a urethral catheter with hematuria. Okay. At the pathological background, the patient denies history of high blood pressure, diabetes mellitus, reports being negative for HIV, denies family history of prostate cancer. At the objective examination, he has a satisfactory general condition, hydrated, conscious, and collaborative. At the vital signs, he has a blood pressure 208 and 105, heart rate 68 per minute. He has a normal cardiac and respiratory system. For digital rectum examination, he has an enlarged prostate, grade 2, hard and stony consistency, thin and small, smooth surface, and without nodules. The laboratory data show the following hemoglobin levels at 13.8, hematocrit at 43, white blood cells count 8.5, normal differential, plaquettes 267, blood urea, it's high, it's 23, creatinine, it's 437. Here, hyponatremia, hyperkalemia with 6.13. He has a normal alkaline phosphatase, and liver functions tests normal. PSA 30.4. We did a chest X-ray, it was normal. Prostate ultrasound with 25 grams of prostate, homogeneous textures and without nodules or calcifications. We did a guided finger biopsy of the prostate that revealed Gleason 7, 4+3 prostate adenocarcinoma. So he now has a diagnosis of Gleason 7, 4+3 adenocarcinoma of the prostate. Also, he has a diagnosis of arterial hypertension with a chronic renal failure. During the hospitalization, the patient was medicated with hydrocortisone, amiloride half in a day, nifedipine 1 in a day, and lisinopril 1 twice a day. He has pending cardiology and a nephrology evaluation. We plan to do in a radical prostatectomy. So the case study, we were discussing this case, and we must remember that it is important that the exam that we chose, or as I can say, we did the biopsy finger guided. So this method is not that efficient on account of the lack of the visual guidance, making the best method the echo-guided biopsy of the prostate. We're not doing this in Mozambique. We're still doing the finger-guided biopsy, and there have been also insufficient studies made to correctly assess the stage of the cancer, as well as to discard metastasis. Therefore, a CAT scan over the pelvic abdomen or MRI and a bone scintigraphy would have been good to do just to discard bone metastasis. Also, the patient shows already signs of chronic renal disease, making the nephrology evaluation necessary pre-surgery. As we can see, this patient already has high blood pressure, making we had to postpone 2 times the surgery because we can't put down the levels. So it is a new case of high blood pressure, and also we need to see a cardiology evaluation before the surgery. So this is the case that I prepared for today. Okay. How do I?
Well, thank you for presenting the case. It's a very interesting case. A few things came to mind as I was listening to your presentation. So you mentioned finger-guided biopsy, and that's something that to be honest, I've never seen or experienced. And I was just curious, with the finger-guided biopsy, how many cores are you able to take from that?
Normally we take 12. We do this, we do everything without seeing. We try to give an imagination. So we have the prostate. We divide it on 3.
Okay.
The left, we take 1 in the up, the middle, and then down, and then we do this 4 times. The left side we take 6, and the right side we take 6. But that's not effective because we can't see if we're doing it right or not, and we also can see if this patient has nodules in the prostate. We might not catch them.
Yeah, for sure. Is the patient, is this done typically under anesthesia or is the patient awake?
Sometimes we do under anesthesia, but mostly we do the patients, we do them awake because we don't have enough space to take every single patient to do it under anesthesia.
Yeah, I can imagine.
So a lot of them, we do them without any. We just use some painkillers before and after.
Yeah.
And that's it.
And you had mentioned MRI as part of your metastatic workup. Do you have access to multi-parametric MRI of the prostate, or were you talking about just sort of a staging MRI of the abdomen?
It should have been good. Actually, we have at the hospital, but I think it's not working, and we've never asked for one. When we try or we're doing the staging, usually we ask for a CTA and sometimes an X-ray just to see if the dorsal,
Yeah, the spine.
the spine has signs of metastasis or not, and also the chest to see if we have lung metastasis or not.
Okay.
Yeah, sometimes we lack to stage because of the limited access.
Yeah.
For example, we don't do bone scintigraphy here.
Okay.
MRI, I've never seen a patient with prostate cancer doing MRI at our hospital.
Okay. Interesting. So when you do the plain films to rule out bone metastases, you would do the spine, the chest, and the pelvis?
Yes, yes. And if a patient shows signs of, for example, if he shows neurological signs, we also ask for a brain scan.
Yeah.
Just to discard.
Yeah.
And basically what we do is look for signs to see if they have or not metastasis. Then what we do is we ask for the exams.
Right. Yeah.
And the problem with those patients is that they they come to the hospital really late. We don't have a patient who just goes to the hospital to do a prostate scan.
Yeah.
It's really rare for us to have a patient who does this. Most of these patients, they have, most of the time it's because they have hematuria. So they get scared and they go to the hospital. That's when we...
Yeah. Yeah. Unfortunately, it's a disease that tends to be asymptomatic until it is quite advanced stage. I think that's probably one of my main concerns with this patient that you presented with a PSA of 30 and a small prostate. I would definitely do as thorough of a metastatic workup that I can. You know, with his creatinine being over 400, of course, I don't think you'll be able to give him contrast for his CT scan, but I think a non-contrast scan is probably better than nothing, and you'll still be able to assess some of the bones as well. But
Hello.
so yeah, I would say just do a thorough metastatic workup as you can. But the reality is, I think there's definitely a chance that he may be metastatic already. I'm curious if in metastatic settings, how do you treat the patients? Do you do surgical castration, or do you use Leucron or kind of injection type ADTs?
Yeah. At first, we do hormonal, I don't think if we say that, we use Zoladex.
better.
Hello?
Yep. Yeah, we can hear you.
So, as I was saying, at first we do a chemical castration. And if the patient respond well to that, we do a surgical castration. If they don't, we just send them to how can I say it? We send them to the oncologist.
The oncologist, medical oncologist.
Yeah. But the problem with the is most of the time when they get to our service, they usually have a PSA above 100.
Yeah.
Most of them, they're terminal cases, basically.
Yeah.
So maybe there's the main problem.
Do you have any kind of screening programs, or do most people just don't usually seek care until they have symptoms?
Oh, we have some, but this is something new for everyone, especially in the provinces.
Mm-hmm.
There's healthcares who don't even know how to do it or what to look for. Maybe if we talk more to the populations so they know that this is real, and also because our culture, we don't have men who just go to the hospital to see if they're okay, right? So this is a problem. This is a basic problem that we have, and we need to solve this by educating the population.
Yeah.
First, we need to show the population, to teach them and to tell them that this is a real thing. And maybe after that, we will have a better, how can I say it? A better outcome of them. Maybe they will come to the hospital without any symptoms, or just to see if they're okay or not.
Yeah, absolutely.
And sometimes when we get those patients, what we do is that we call them and call all the men of the family, so we can try to test as many as we can.
Yeah, absolutely. Absolutely. Early screening is the key. A lot of the times here in North America, the screening is done by the primary care physicians, the family doctors. The reality is it's actually quite rare, I think, as a urologist. Sometimes in general urology, you'll have that discussion, but a lot of times I think when it comes to screening, it's really the family doctors who are the people to target, because they're the ones who are going to be seeing the patients first. They might be seeing them for other reasons, or screening them for other conditions, or treating them for other conditions, and that's sort of an opportunity while you have them in for something else to do the screening.
Hello, Dr. Chamo, may I ask a question to Dr. Beatrice, please? May I? Okay. I was listening carefully to Dr. Beatrice, and one of the things is just culturally, I don't know, Mozambicans, maybe somewhere else, there is no such good practices of coming to the hospital for a checkup. Okay. But my point also is that I've listened quite a lot on breast cancer being, let's say, bringing awareness to the people on the radio or even in different meetings with people. But I'm not aware of any kind of awareness being done in relation to prostate cancer. Is that myself, I've never heard about that? Or there is no much focus on this? And if this is the case, is there any plan which could be a more general plan So to make sure that the Mozambicans and other people living in Mozambique are aware of the need to, in a preventive way, to go to the hospital to check for that. You know, we have listened about malaria, now is COVID, I mean, it's widespread. I mean, advertisement and make people that are aware of this. But on prostate, I don't think I've heard that much. It's me, I'm not paying the necessary attention, or usually there is no much done in this sense. And what Dr. Beatrice should think should be done to make sure that more people join this. Because as I see, there are a lot of people that are suffering from prostate cancer in a way. At least I know some of them, and regrettably, some of them died. So that could be one way. Is there a awareness campaign? Is there a plan to do that to be done, or what do you think?
Thank you, Dr.
Go on. I will assist you later about that.
Thank you. Well, thank you, Dr. Banze. First of all, start by saying that, yes, we're doing our best. Sometimes our professors, for example, Dr. Nelson, most of the times you can see him in television, national television, talking about this problem. And as well as, especially when it's November, Blue November, we do some campaigns on big or small companies. We even go for runs. We try to give the information in the way that we can, but I'm sure that we're not doing enough for that. And also, we must not forget that when men hear about prostate cancer, what they think, the first thing that they think is that it will be a finger up my ass, right? So they're like afraid of that. They feel like I've heard men saying that I prefer to die than for you to do this to me. So what makes me think is that, yes, we need to work more for that. Yes, we need to put a lot of effort for that. We need to do more, but also this is a problem, but that we need to fix from the education, right? We need to start doing this kind of talking with not just men who are 40 years old up, but since the young age. I don't know if I'm making myself clear. We need to put everyone in this. We need to include everyone. We need to include women. We need to include men. We need to include children, because this is something not just people don't know, but even when people know, they're afraid to go, because this kind of thinking, or this this stigma that we have. And sometimes I have to calm down the patients and say, oh, we will just do a blood exam. I won't do anything else to you. Because yes, people are afraid, and especially men, they feel emasculated when someone says something so, how can I say, when they hear about prostate, what they hear is that the doctor will do this to you. I don't know if I make myself clear. What they understand from prostate exam is that the doctor will always have to do that digital rectum exam, and that's why most of the men who already know about that are afraid of. So this is something that we need to work from the younger to the oldest, and include everyone, women, everyone needs to be included in this, not just men.
So let me assist you, Dr. Leland. The prostate cancer problem is a big issue worldwide. The problem when you talk about breast and cervical cancer, they are receiving more attention. That's true, absolute true. And this is all the trend. It's not only about Mozambique that is not paying attention for men's health. If you look for all the main health indicators and you compare men to women and children, you will see from far that men are not receiving enough attention for life. So this is a really big issue, and fortunately, the Minister of Health right now decided to give, with the presentation from Dr. Lilande, we could see that we have several limitations to make diagnosis of prostate cancer. I think the first limitation is the number of urologists that we have in this country. I can count with my fingers the number of urologists in Mozambique. So that is terrible, and we are 30 million. And the second reason is that screening of prostate cancer is really expensive. You know, the basic tool to make this screening is the PSA, and the PSA is really expensive test. Of course, it's more easy to make a diagnosis of breast and cervical cancer because the tools that you need to do that, they are less expensive, and also because we are paying more attention for human health. Another question is that the WHO, the World Health Organization, doesn't recommend to do a massive screening for prostate cancer. That is not the recommendation. So we don't do maxi. But for sure, we are doing less that we must and we should do. We are doing really little about that. And the lack of tools to deal with prostate cancer in this country is really terrible. Is how you could see in this clinical case that Dr. Leland make the presentation. The highlights of problems of this cancer are all there. You don't do CT scan, you don't do MRI, you do finger-guided biopsies. It's not possible to make accurate diagnosis with the finger guide. And we are not staging the prostate cancer in the appropriate way. And we cannot say for sure that we are making the best plan to treat these patients. Okay, so I agree with Dr. Leland with all the points that she is raising in the clinical case. And of course, Dr. Barnes, I fully agree with you that we are far enough from what we should do.
Well, that was really interesting, and thank you for sharing. You know how prostate cancer is managed, and in your country, and sort of some of that cultural barrier and education and that still needs to be done. I think you bring up some really great points, and it was just very interesting learning experience for me also to hear that. So thank you for sharing. So I guess just to wrap up, is there any other questions or comments or anything else that I can help address?
Just a point. Are you listening?
Mm-hmm.
I don't know. Yeah. It's worth to do screenings when you have something to offer to patients. If you do screening, you find a lot of oncological problems. You need to have a solution for those patients. If you don't have a solution for those patients, it's not worthwhile to do screening, because what are you going to say to the patient? Yes, you have a cancer, but I can do nothing to you. So I think in Mozambique, about 30 million people, like Nelson said, how many urologists are there? How many radical prostatectomy it's possible to make during a year? We don't have radiotherapy. So what we're going to do, it's worthwhile to do screening? That's my big question.
I think that's a really important way of looking at that. And you bring up a really good point. I guess my thinking is, certainly the limitation, the lack of resources and access to care, and these are sort of bigger issues, beyond what we can address in our hour. But ultimately, I think the idea is that if you are able to, certainly if you have the resources and you are able to do something for the disease a little bit earlier on, before it becomes metastatic, I think there's still value in that. Not just necessarily for prolonging life, but also for quality of life. I'm sure you must see a lot of cases of metastatic prostate cancer, and it's a lot of suffering. And if we can do anything to avoid them reaching that stage, even just for quality of life and symptom control, there can be some value in early detection.
Doctor, I have a question. So in your experience, what is the most effective way to do a screening prostate cancer? Is it a digital rectum exam or a PSA?
I would say, a lot of factors, what you mentioned about the cultural barrier for the rectal exam, if the patient really doesn't want to have a rectal exam, but they can accept a blood test, then, the blood test is, first of all, better than nothing. And there is some literature suggesting that when it comes to actually screening, the PSA is probably actually a better marker than the physical exam itself. Because the reality is, if you want to catch his cancer early enough, where it should technically not even be palpable, so the PSA would be a better marker. Cost is certainly an issue, which I think Dr. Chamel had brought up, but if you are going with the screening route, I would say, at least even one PSA in someone, in their 40s, that can be already better than no screening at all, and it gives you some indicators to how closely you need to keep an eye on this person. So for example, if their PSA at age 45 is 0.5 or even lower, you're pretty reassured that the likelihood of this person dying from prostate cancer, even years down the line, it would be lower than somebody who has, let's say PSA of 2 when they're at age 45. So I think that, in the setting of limited resources, that early baseline PSA is probably more valuable than repeated screening.
Thank you.
All right, great. Well, thank you so much for having me. It was really a pleasure meeting everybody, and also just hearing about your experiences and bring your case. This was a really wonderful discussion, and thank you for inviting me.
Thank you so much, Dr. Yu.
Thank you. Bye-bye. Thank you.
Bye-bye now.
Thank
I
you.
think
Thank you. Thank you very much. It was a really interesting class.
You're very welcome.